Good morning, everyone, and welcome to the Friday morning Academic Department of Internal Medicine meeting. This morning, it's really a real privilege for me to introduce Dr. Candice Birch, who's a fellow in intensive care medicine and, in fact, an excellent fellow. Really great to have her in the unit, and she does an absolutely great job. And she's going to address an entity that, is very topical, certainly in acute care settings, that's ARDS, and some of the supportive measures. And even in a hospital like this, from time to time, we can, in fact, do things like ECMO. And Candice is certainly very, very well qualified to chat about these things. Not only is she a specialist physician, she's also a biomedical engineer, in fact, a cum laude graduate in biomedical engineering. And as I said, an absolute pleasure and privilege to have in the unit. Candice, we look forward to your presentation. Thank you.
Hey, good morning, everybody. Today, I'm presenting on behalf of ICU in 567. The title of my presentation today is A Case of Severe ARDS Requiring ECMO. So the patient who I'm going to talk about today was Mr. VN, a 31-year-old male patient whose background of HIV negative, who presented to us with a diabetic ketoacidosis, newly diagnosed diabetic with an HbA1c of 14.7%. There was a concern for acute pancreatitis in the emergency department, and the patient was taken for a CT scan. He was sedated with midazolam as he was agitated. However, he subsequently aspirated at scan. He was on the DKA protocol in the emergency department for 2 days until waiting for a bed with us in ICU. He was admitted to the ICU on the 5th of February and intubated for a type 1 respiratory failure. He subsequently developed ARDS with a PF ratio of 56 and also required dialysis for an acute kidney injury. So on the left was his admission X-ray in the emergency department, and on the right is his X-ray about 2 days later, still in the emergency department post-aspiration. So first off, a definition of acute respiratory distress syndrome, or ARDS. We use the Berlin definition. So this requires all 4 criteria to be fulfilled. It would be an acute onset within 1 week, diffuse bilateral lung infiltrates on imaging, infiltrates of which are of non-cardiac origin, and a partial pressure of oxygen ratio to fractional inspired oxygen ratio of less than 300 millimeters of mercury. And that can further be subdivided into mild, moderate, or severe based on the PF ratio, with mild being PF ratio of 200 to 300 millimeters of mercury, moderate 100 to 200 millimeters of mercury, and severe less than 100 millimeters of mercury. ARDS occurs in about 23.4% of intubation patients in the ICU and carries a large in-hospital mortality of 30 to 40%. However, most patients do not demise from ARDS, they die from multi-organ failure. So just recap on the pathologic stages of ARDS, of which there are 3. The early exudative phase, which occurs on around day 7 to 10 with diffuse alveolar damage. This shows non-specific, or it's a non-specific reaction to lung injury with interstitial edema, acute and chronic inflammation, type 2 pneumocyte cell hyperplasia, and hyaline membrane formation. The fibroproliferative stage, which occurs around 2 to 3 weeks with resolution of pulmonary edema, proliferation of type 2 pneumocytes, squamous metaplasia, interstitial infiltration by myofibroblasts, and early deposition of collagen. And lastly, the fibrotic stage, which causes obliteration of normal lung architecture, fibrosis, and cyst formation, and this may range from minimal to severe. So just a general overview of the management of ARDS, and I'll elaborate further on the following slides. So always treat the underlying cause if possible. We'll talk about steroids, a conservative fluid strategy. And based on the ARDS NET trial in 2000, traditional oxygen target ranges will be a partial pressure of oxygen 55 to 80 millimeters of mercury, or saturations of 88 to 95%, lung protective ventilation, in the form of airway pressure release ventilation or APRV, permissive hypercapnia, proning, which I won't really go into in this slideshow, and ECMO. So in terms of steroids, based on the DEXA ARDS randomized controlled trial in 2020, in patients with early but established moderate to severe ARDS, the use of dexamethasone, in addition to standard care, will significantly increase the number of ventilator-free days and significantly reduce mortality. For conservative fluid management, this is based on the Fluids and Catheters Treatment Trial, or FACT, of 2006. Although there was no significant difference in primary outcomes at 60-day mortality, conservative fluid management, it does improve lung function and shorten duration of mechanical ventilation and intensive care. Pulmonary edema can occur in patients with ARDS because there's increased vascular permeability, which is intrinsic to the pathogenesis of ARDS. And it also occurs due to aggressive intravenous fluid management, which happens prior to, or with resuscitation prior to intubation. So the way to address this issue in the ICU is to discontinue or restrict fluids and or give diuresis if necessary. And if fluid status is unknown, you should consider using monitors to assess fluid status. And the aim is to target euvolemia. So airway pressure release ventilation, which we use in the ICU, is a recruitment mode and allows for recruitment of lung tissue while minimizing barotrauma. In a Chinese study conducted in 2017, they compared APRV to conventional low tidal volume ventilation and found that the number of ventilator-free days up to day 28 was significantly greater in the APRV group compared to the low tidal volume group. And the median ventilator-free days in the APRV group was 19, compared to the low tidal volume group, which was 2 with a significant p-value. APRV resulted in significantly better markers of oxygenation and ventilation, such as better PF ratios, better lung compliance, and lower peak and plateau pressures. It also resulted in lower heart rates and higher blood pressures, less sedation depth with lower doses of propofol, and extubation rates were higher in the APRV group with fewer tracheostomies. And important to note is that APRV reduces the incidence of progression to ECMO. A caveat here is that many centers and providers lack experience with APRV and should only be used if people are experienced with it. In terms of permissive hypercapnia, this is the practice of intentionally allowing the partial pressure of carbon dioxide to rise in order to promote lung protective ventilation, and that is according to the ARDS net trial. Most guidelines will suggest a pH of more than 7.2, but this is arbitrary. In severe cases, you can even accept a lower pH. And in their trial, they used IV bicarbonate in order to improve the pH to promote lung protective ventilation. So further going on to ECMO, which is extracorporeal membrane oxygenation, of which there are 2 types, veno-venous and veno-arterial ECMO. So veno-venous or VV ECMO supports the lungs by extracting blood from the right atrium, oxygenating it externally, and then returning it to the right atrium. And veno-arterial or VA ECMO, blood is extracted from the right atrium and returned to the arterial system, bypassing the heart and lungs, providing both respiratory and hemodynamic support. So I won't say anything further on VA ECMO. So VV ECMO, which is what we use for our patient, has specific indications. So mainly in patients with hypoxic respiratory failure with PF ratios of less than 100, this would be despite optimizing ventilator settings. That would include tidal volumes, peak end expiratory pressures, and inspiratory to inspiratory ratios. Other indications include hypercapnic respiratory failure with arterial pHs of less than 7.2, and as well as patients who require ventilatory support as a bridge to lung transplant. So before starting ECMO, questions to ask yourself are, does the patient have acute severe respiratory distress as an indication? Is the etiology reversible? Is this patient or is the patient refractory to conventional management? And are there any contraindications to ECMO? And the only absolute contraindication would be a patient with anticipated non-recovery. In other words, a patient with severe neurologic injury or end-stage malignancy. So what does the evidence say about ECMO? So there are two major trials, the first being the CMJAH trial in 2009, where they compared 180 patients with severe ARDS, randomized either into one ECMO-capable center or into 68 other hospitals in the UK where they are already receiving conventional treatment. The primary composite endpoint was death or severe disability at 6 months, and this was significantly lower for patients randomized to receiving ECMO at 37% versus 53% with a significant p-value. However, the CMJAH trial did not compare ECMO to non-ECMO. 24% of patients in the ECMO group never actually received ECMO. They did, however, or most of the patients received lung protective ventilation, as well as in the control group, 70% of those patients also received lung protective ventilation. So this study did not conclusively prove that ECMO was effective, but it did show the importance of a lung protective ventilation strategy in severe ARDS. The second trial was an international randomized controlled trial known as ECMO to Rescue Lung Injury in Severe ARDS, or EOLIA, in 2018, which compared early veno-venous ECMO with standard lung protective ventilation in patients with severe ARDS. It was stopped early at 75% of recruitment due to predefined futility rules. Basically, they knew they weren't going to reach their predefined outcomes. So the primary outcome was no statistical difference in mortality at day 60. The ECMO group at 35% versus the control group of 46%. There was no statistically significant difference between the two groups, with a relative risk of 0.76 and a non-significant p-value. The EOLIA trial provides inconclusive support for the benefit of ECMO in severe ARDS. However, the data also suggests a possible clinical benefit over standard care, especially if used early, less than 7 days rather than late. And finally, there aren't many studies, but pooled mortality data from those two trials and 3 observational trials on VV ECMO for severe ARDS at a total of 773 patients concluded that ECMO was associated with a significant reduction in 60-day mortality compared with conventional ventilation, with a relative risk of 0.69. So our patient was managed on APRB. He was started on steroids. VV ECMO was initiated on the 26th of March. We use unfractionated heparin as an infusion, and this is started prior to cardiothoracics being consulted, and they come and cannulate the patient, and cannula was inserted into the right jugular vein, right internal jugular. Anticoagulation is sustained while the patient is on ECMO, and it's monitored via something called an activated clotting time, or an ACT, and the value that we aim for is 180 to 210 seconds. And this is done by a point of care test that's available at the bedside. So this is our patient's X-ray after cannulation. You can see the cannula there. So just in terms of ECMO cannulation, just a basic circuit diagram. Blood is taken from the venous cannula, placed in the internal jugular vein, and returned through a cannula with its tip at close proximity to the right atrium. That's either through the right internal jugular vein, as with our patient, or can also be done through the femoral vein. So this is a better diagram of the ECMO circuit. So the deoxygenated blood will be taken from the patient by an access line under negative pressure, and that's provided by a centrifugal pump, as seen there, entering an oxygenator where gas exchange occurs. So the oxygenated flow on the machine is controlled across a hollow fiber membrane. Blood flows on the outside of the fibers, and gas flows through the fibers in a countercurrent flow pattern. And that gas exchange occurs through diffusion between the concentration gradients between oxygen and carbon dioxide. And then oxygenated blood is then returned to the patient by the return line. So the way to titrate the ECMO is after cannulation, the patient is connected to the circuit, and then you control the blood flow until the respiratory and hemodynamic parameters are satisfactory. And reasonable targets to achieve are an arterial hemoglobin saturation of more than 75%, which is measured on the arterial side, and a venous hemoglobin saturation of 20 to 25%, lower than the arterial saturation, which is measured on the venous side. Adequate tissue perfusion is determined by arterial blood pressure, venous oxygen saturation, and blood lactate levels. Just in terms of carbon dioxide removal, there's gas exchange, as mentioned, from the oxygenator, and that takes CO2 removal from the blood, and that's controlled via what's called a sweep gas inflow rate to the oxygenator for a given oxygenator membrane size. So carbon dioxide removal increases with an increasing sweep gas flow, and that sweep gas typically ranges from 1 to 9 liters per minute and very effectively lowers the partial pressure of carbon dioxide. And upon initiation of ECMO, we can start the sweep at 2 liters per minute. So the RPM, the revolutions per minute, is basically the flow through the circuit. So the higher the RPM, the higher the rate of flow through the pump. And the sweep, as I mentioned, is for CO2 removal. And the fraction of inspired oxygen and the sweep gas flow are adjusted according to the pre- and post-membrane blood gases. So this was actually the machine that we used for our patient. So you can see the drainage cannula, which is the venous drainage, which goes through the pump, then through the oxygenator and back through the return cannula. And on the right-hand side is the gas blender, where you adjust the FiO2 and the carbon dioxide level. And there's also air there in the middle. So other supportive management for the patient, because platelets are continuously consumed during ECMO, because they are activated by exposure to a foreign surface area, you need to maintain them greater than 50, and that may require platelet transfusion. And then because, as we know, oxygen delivery depends on the amount of hemoglobin and the blood flow. However, the risks of the high blood flow due to shear stresses outweigh the risk of transfusion. So hemoglobin is maintained over 12 grams per deciliter. In terms of ventilator management, this is still important on ECMO. We still maintain the key principle of lung protective ventilation. However, because gaseous exchange is primarily supported by the ECMO circuit, not the lungs, the ventilator setting should still be chosen to minimize lung-induced or lung-induced injury, ventilator-induced lung injury. At a minimum, rest ventilator settings should be targeted at values established in the previous trials mentioned, the CSAH and the earlier trials, the fraction of inspired oxygen at 0.3 to 0.5, plateau pressures of less than 25 centimeters of water, or inspiratory pressures of less than 15 centimeters, with peaks of greater than or equal to 10 centimeters of water. Important to note are the complications that can occur on ECMO, the biggest ones being bleeding and thromboembolism. Bleeding may occur in 30 to 50% of patients. This is, of course, due to anticoagulation with heparin and platelet dysfunction, and that may occur at the cannulation site, at surgical sites that the patient may have, gastrointestinal site, or intracranial bleeds. Thromboembolism may occur in the form of deep vein thrombosis with cannulation, and that can occur up to 70% of patients, and thrombus formation within the circuit causing pulmonary emboli has been documented at up to 16%. Other complications include hemolysis in 5 to 18% due to shear stresses and turbulent flow within the circuit, neurologic complications at 7 to 9% in the form of neurocognitive disturbances, seizures, intracranial hemorrhage, and brain death. And then, of course, sepsis, systemic inflammatory response syndrome, renal failure, and also directly related to cannulation in terms of vascular injury in less than 5%. So just a short word on ethical considerations. So as Prof. Mer mentioned, we are able to provide ECMO. However, there are large resource implications. We need input from other departments in order to initiate our ECMO, and the costs are quite large for patients, so we don't routinely do it on every single patient. They have to fulfill specific criteria and indication. So this was our patient's X-ray, the last X-ray that we have from our patient. So the patient was on ECMO, continuous veno hemodialysis and adrenaline at 1.5 micrograms per kilogram per minute. However, he was in multi-organ failure and had a pH of 6.9, a lactate of 22, and he subsequently had a cardiac arrest with asystole and demised on the 1st of March. Thank you.